Okay, so you all can see everything that's happening over there. All right, I think it's picking me up on, yeah, it's picking me up on the microphone. So that's fine. Let's just make this as loud as possible. Okay, because there's a few videos on this as well. All right, so last week we did the easy one, all right, which was non-shockable rhythms. All right, so I know you'll all remember it perfectly, but I'm just going to tell you guys one more time. All right, so you remember, patient comes in, we feel for a pulse, we start CPR. Can you just answer this for me? It's Elizabeth. Just tell her we're in a meeting. Tell her I'm coming now. What you call it? We start CPR, bag mask ventilation. We give adrenaline, continue with bag mask ventilation, check for a pulse, continue. All right, at a rate of 30 to 2. All right, so you guys remember all of that? Good. Okay. We give adrenaline every 4 minutes and we go ahead. But the reason why we needed to do that was our phone was off in the first place, right? If you remember the analogy that we used, right? Your heart is like your phone. You need to, normally you have to switch it on and off to put anything, right? In this case, the phone was not even switching on. Now we come to the other one, which is shockable rhythms, all right? So shockable rhythms means your phone is coming on, but there's something else going wrong. So for example, the apps are crashing. There's a glitch on the screen, whatever it may be. Now is the time when you need to switch it off. And then hopefully when it switches back on, it will work as normal. So that's what defibrillation is. Defibrillation is quite simply switching the heart off to let it restart in the right manner. Okay. And it works. It does work. Don't worry. Okay. Sorry, let me get this going right. So there's only 2 shockable rhythms. Okay, so don't get worried. It's not like we're going to be sitting here for an hour or 2. Okay, there's literally only 2. Now, this is the algorithm that we normally go through. Okay, and this is the one that gets everybody very confused. Now, if you look at it really, let's compare it to the last one that we did. Okay, so we've got a patient who's got a rhythm. All right, now in this case, it's not asystole or PEA. All right. So don't worry about this for 1 second. So we've got a patient in a rhythm. What do? CPR for 2 minutes. And then we going to give, let's forget about this now. What are we going to give? Adrenaline. All right. We're going to continue CPR. And then we've got another drug that comes in here. All right. So basically all that we're adding is 2 extra steps to what we learned already. So we already know how to do CPR. We already know how to give adrenaline every few minutes. What we are adding on is a shock, when to give the shock, and if adrenaline is not working, what else can we add on? All right, so that's basically it. Now, we're going to go through it step by step. So if you get a patient who gets one of these 2, let's see, I've got it on the next slide. All right. Oh, okay. Well, the 2 are ventricular fibrillation. All right. Do you have any idea what ventricular fibrillation looks like? It's just like a jumping line, all right? It doesn't look like any particular thing. It's just moving at random, all right? And a pulseless ventricular tachycardia, which I'll show you just now, right? So you have ventricular tachycardias with a pulse, and you have ventricular tachycardias without a pulse. So this, in other words, we feel the patient, there's no pulse, but we can see this ventricular tachycardia. So as soon as you see that, your phone is on, but it's not working properly. So the first thing you are going to do is switch it off before you do anything else. Switch it off by defibbing, which I'll show you just now, and then you release. All right. Now, the problem is when you defib the heart, even if you do it properly and if the heart is going to come back to normal, it takes the heart a good few beats to actually get back up to where it should be. So you support it for the first few beats. So you still got to do CPR, all right? And you remember you're watching your monitor in this time. So you're trying to see, is there an organized rhythm coming back on it, all right? Now let's assume the first shock doesn't work. So we do our CPR for 2 minutes. We check our pulse and we check the rhythm. All right, for now, we'll just talk about ventricular fibrillation. So again, is it working? Is the rhythm shockable? In other words, is the rhythm shockable? Yes, the rhythm is still shockable because the phone is still glitching. Our heart is still glitching. So we can shock again. All right, we can give the patient another shock, and then we give them adrenaline, like what we did before. So adrenaline is just to give the heart a good punch. All right. Sort of like on your phone, percussion maintenance, when you hit your phone against the edge of something in the hope that it will start working because you just got it on contract. It's like $2,000 a month, So you're like, that's what adrenaline does to the heart in this case. All right. And then you look again, is it still glitching? And if it's still glitching, you shock it again. All right. The only difference being that now, after the third shock, all right, after the third shock, you now give amiodarone. All right. So those of you who have been working here, you know that we use amiodarone. What do we use it for? Well, majority of the time when you guys have been here, we use it for one particular thing. Supraventricular tachycardia. All right. It tends to slow the patient's heart down. All right. We'll get into why it does that. All right. And then we just come back again on the cycle. So rhythm shockable, yes. We shock. We do CPR, adrenaline. We check for a rhythm. Is it shockable? We check for a pulse. There's no pulse. We shock and we give amiodarone. So it's just this little part at the start that's a little bit different. All right. So we're going to come back to this and we're going to practice it amongst ourselves. All right. And I'll leave it up on the screen so that there's no blank faces. All right. So what is ventricular fibrillation? Let's have a look at ventricular fibrillation. All right. These are the causes of ventricular fibrillation. There's all of that going all the way down. All right. No, don't stress. You don't have to write all of this down. These are all these long causes. If you're really stuck, you can go and Google it while you're waiting. All right. But essentially, it's very difficult to narrow down the cause in the few minutes that you are resuscitating. All right. Because you're not going to be able to see if there's an aortic dissection while you're busy. Busy with the patient. You're not going to be able, for example, to see if there's primary pulmonary hypertension while you're resuscitating the patient. This is for afterwards. Once the patient is stable, then you try and go into what could have happened. There are a few that are quite interesting, like electrical shocks, drowning, hypothermia, seizures, ischemia, cardiomyopathy. Those are things that we can see quite easily. Okay. All right. Now, hope this thing will play.
Yo, Lifelink. Hey, Jim Owens Jr. here.
Oh, sorry. So this video is just going to explain to you, where did it go now? How fibrillation works, right? Could you guys hear it? Not at all. Let me just see why. Speaker. Okay. Just take this out for a little bit. Okay. So the next one we're going to see is about atrial fibrillation and ventricular fibrillation, right? So he does it in a very cool way. So let's just have a look at it.
Jim Owens Jr. here at County Hospital. We're in the cardiac cath lab. And this right here, this is the place where we save hearts and we save lives, and it all starts right here in this lab. So today we're going to be talking about defibrillation 101. And what defibrillation is when you have somebody that comes into this room, into the emergency room, whatever, and they're in a lethal rhythm like defibrillation, VTAC without a pulse. And what we do is we grab these paddles right here, hit them with a nice little jolt of electricity, and what we're doing is we're actually stopping the heart so that their regular rhythm can be restarted. All right, so let me break this down for you, fellas. Layman's terms, quick and simple. Your heart is electrical and it's also mechanical. If you have something that happens with your electrical part, then it's going to affect your mechanical and vice versa. So when you actually have fibrillation, it's your electrical part that is causing the muscle to fibrillate or just quiver. Okay, so let me break this down for the ladies, okay? Say you're out shopping with your friend, she starts bugging out about the cell going on at Macy's, and she gets all high pitched, and she gets all squirrely like that. And so you catch her with the back of the hand, knock some sense back into her, and she's back into her regular rhythm. All right, so whenever your heart's in VFib, what actually happens is instead of having a good positive squeeze like this and getting blood flow out to the body, to the brain, all the vital organs, what it does, it just quivers like this, okay? So essentially, your body's not getting any blood flow, it's not getting any oxygen. Pretty soon you're gonna die. Pretty soon you're gonna die. So what I'm gonna do is I'm gonna give you a little dance that shows you how your heart's supposed to work, okay? Pretty simple. This is your atria squeeze, okay? Atria, and then your ventricles, okay? So atria, ventricles, atria, ventricles, atria, ventricles. That is sinus rhythm. That's everybody's heart should be in that rhythm right there. Atria, ventricles, atria, ventricles, atria, ventricles. Now I'm going to show you what happens with VFib. Basically, sinus rhythm, okay, sinus rhythm, right? And then something bad happens, and then I start just quivering. When you see that dance, that guy's got HGD. He gonna die. So right at this point, what's happening is your heart's fibrillating, just quivering like a little jelly, okay? You're bugging out, you're fading out, you're hoping you made yourself right with God. At that point, somebody like me steps in the room, grabs the paddles, hits you with a little bit of electricity, zap, bring you back to life. That, my friends, defibrillation 101.
Okay, got it. So just a fun little video. All right. So let's see what this looks like. All right. So this is what VFib looks like. All right. So it's 15 minutes in 15 seconds. All right. So to understand why it's so dangerous or why it's such a problem, just take your hand, all right, put it like this. All right. And just do this. All right. Easy, isn't it? Nothing wrong with that. You could probably do that for an hour or two without any problem. Now try and do it in an uncoordinated fashion. Just try and move your fingers in and don't coordinate it at all. Just try and do it. Can you already feel it's starting to feel a bit weird? You can't keep this up for very long. You know, you can keep it up, but it's using up a lot more energy than a normal beat like that. All right. So that's essentially what's happening here. Okay. So the heart is fibrillating. Number one, it's got no cardiac output. Number two, it's using up all its ATP stores very quickly. All right. So that's essentially why a fibrillation is such a problem. Okay. All right. Let's go to another one. It's supposed to be here. All right. So this is a VFib. All right. That's what it looks like. It's got no particular pattern. All right. And this particular one is called a coarse VFib. Now, just excuse me. This thing here, I made the slideshow when I first learned about animations in PowerPoint. So I overdid it a bit. All right. So I'm just letting you all know, all right? You can see, it's like even I got irritated with it after a while. And this is called a fine VFib, all right? So if you have a coarse VFib, your patient still has ATP. So it's able to give fibrillations, but at a much higher output, all right? That's when you've got your best chance of actually getting your patient back. Once you start going to a fine VFib, your patient started using up all the energy stores in the myocardium. So once you see this, you're getting very close to a flat line, all right? And once you do get to that flat line, it's even harder to get your patient back because now there's no energy stores within the heart itself, all right? Okay, and a pulseless ventricular tachycardia. Right, so that's what pulseless VT looks like, right? So that's what ventricular tachycardia looks like, all right? In any case, vampire's teeth, all right? Or a whole lot of mountains, or a whole lot of monster teeth, whatever you want to think of it as, all right? The difference with this one is that it's pulseless. So as soon as you check for the pulse, there's nothing, but that's what you're seeing on your screen. This is the algorithm for a pulsatile VTAC, right? Which we'll get into one of the days. So in other words, if you just start treating the patient according to this, the patient will never make it. This is your patient having a pulse, but having a tachycardia. We're only looking at the algorithm that we had before, right? So let's talk about defibrillation.
Hello and welcome to video 3.
1 second.
In this video, we will learn everything.
External defibrillator, all right? Yeah.
Hello and welcome to video 3. In this video, we will learn everything AED. Let's get to it. AED stands for Automated External Defibrillator, and they are very easy to use, and to show us how, here is the AED Welcome.
Today we're talking AEDs. These things you can work in 3 easy steps. That's right, 3 easy steps. The first one, turn it on. If you forget anything else, just turn the thing on. Number 2, put the pads on. Number 3, follow the prompts. That's right, from then on, it'll tell you what to do. If the person needs a shock, it'll light up. You'll press the button, shock the person. If it doesn't, it'll tell you no shock advised, and you'll continue CPR. Look at how amazing these things look. Can you imagine that thing just hanging on your wall in your home, your office, place of work, whatever? That's right, you can have this machine.
Okay, enough with the sales pitch. Let's take a look at the steps. Step 1. Tone it on.
Step 2.
Put it out, put it out, put it out.
Step 3.
And every 2 minutes, we'll do it all over again. That's it.
Boom, that's it.
Okay, let's talk some special considerations.
Medication patches, take off and remove gel. Hairy chest, shave or wax off. Water and electricity equals bad. Person with the pacemaker.
You got that person with the pacemaker up here? Instead of putting it right here, just move it about an inch away.
Piercings,
No bother.
a few more things. Adult pads okay to use on everyone. Child pads use on 8 years or younger. Infant pads are key, use only on infants. 2 or more people.
If 2 or more people work together,
Stand clear.
Oh.
Button to deliver.
Press the button.
keep going until those 6 reasons happens from the previous video.
And that's how you get it done.
Okay, so this is just to show you what they're doing in Bulgaria at the moment and some of the, well, the old Eastern Bloc, some of the European countries, all right? They've got these drones that can fly these things out. Okay, so let's have a look at it and see.
Ambulance drone to save heart attack patients within minutes. Dubbing it, quote, ambulance drone, a student at a Dutch university has developed a flying defibrillator that can respond within minutes after a heart attack sets in. The ambulance drone is equipped with a camera and a GPS navigation system. Powered by 6 propellers, the drone can reach a maximum speed of 100 kilometers per hour. When someone suffers a heart attack, bystanders can call an emergency hotline and an ambulance drone is next dispatched. Using a camera mounted on the drone, a staffer can then instruct bystanders to attach the defibrillator to the patient. The drone can transport the device to someone in need inside a 12-kilometer zone within 1 minute, significantly increasing the survival rate of patients. Apart from the defibrillator, the developer hopes that the drone will be able to carry other medical supplies, such as oxygen masks and insulin injections. The developer aims to create an ambulance drone network in the Netherlands within 5 years.
Did you miss the teacher sex story?
Sorry, that's not supposed to be.
Ambulance drone to
Okay, so this is how you place your pads, all right? So, basically what you're trying to do is sandwich the heart between the defibrillator pads, okay? That's essentially what you're trying to do. So in other words, if you, for example, put one here, and then you put one there, you aren't getting a lot of the heart between it, okay? Or if you place one here and one there, there's almost no heart in between. So you're trying to get as much of the heart between. So that's why we always say you place it at the sternum, all right, or to the right of the sternum and the apex, because that's when you get the most amount of electrical charge going through, all right? So that's the one way that you do it. Again, apologies for the animations. All right, and that's how you do it for a child with an AED, all right? And then the last one, this is how you can do it for kiddies, because there's not much space on the chest. Sometimes you only have access to adult pads or adult paddles and things like that. So that's the way that you can do it for a kiddie. Sometimes for very obese patients as well, because if you place it, by the time you get to the apex is that far away. So you can't place anterior and posterior. The important thing to think is, am I sandwiching the heart between the paddles, you know? That's the thing. All right, so this is our machine. Or at least it was our machine when I did this, all right? It was a Mindray defibrillator, all right? So the first thing that you do is exactly like the AED, all right? But anyway, let's just see. So you've got a few, and most defibrillators look like this. So you have a manual defibrillation setting, all right? You have the AED function, but if you're going to use the AED function, you need to have the pads, all right? Which we don't have, unfortunately, okay? Then you select your energy, all right? Now, the selection of the energy depends on the size of the patient, all right? If it's a small baby, if it's an infant, toddler, So for kiddies, it's 4 joules per kilogram. 4 joules per kilogram. And for adults, generally, we start at about 150 joules. Okay, to 200 to 250. So the machines do go up to 300, but generally you're going to start at 150, all right, on your first shock. Right, let's have a look and see. That's just all the cabling that comes with it. So you've got your SATS monitor, ECG monitor, things like that. So that's what it looks like when you put it on monitor. It will generally give you a 3-lead ECG. It will give you a SATS, and it will also give you a, what you call a breathing and respiratory rate, okay. And that's what it looks like when you select the energy. Now, that's how it looks on most of them. They tend to be standardized because they don't want you to have to know per machine. In other words, whether you use a Mindray machine and then you're going to a Mesa, you're going to whatever machine you are using, it should look the same so that you've got the same type of interface. So you'll find no matter which one you've got, it's got a similar type of interface. Maybe one button more from here or there, or in one you have to press exit, it won't automatically exit. They're small things, but generally this is what they all look like. Okay, right. So that's just a bigger look at it, all right? But if you think about it, you're essentially doing what an automatic external defibrillator does. You're just doing it manually. You are looking at your rhythm, you are selecting your energy, you are charging, and then you are shocking, all right? And if the patient doesn't need a shock, then you don't shock, okay, right? So that's your energy, that's sync, all right? So synchronization, we only use when we have tachycardias. Supraventricular tachycardias, ventricular tachycardias. So don't use that during resuscitation. Okay. Okay, then we charge and then we shock. Just see. Okay, so these are our defibrillator paddles. Okay, we have apex and we have sternum. Please do not mix them up. Okay, apex goes at the apex, sternum goes at the sternum. Okay, now you've got all your buttons on the defibrillator handle. So in other words, you don't have to let go and press on the machine, charge, and you don't have to press to shock. Here's number 2, which is energy selection. So every time you press it, it automatically goes up. And as soon as you press the two orange buttons together, that's when you discharge. All right. Now, if somebody can also stand by the machine and do it for you. It's not a problem. All right. Sorry, that's just to show what it is. Okay. Oh, sorry. That's your energy selection. Yeah, energy selection button. Sorry about that. Okay. Let's have a look at what's next. Right. So I'm guessing we all know the Hollywood rubbing method. All right. Everybody knows the Hollywood rubbing method? Yeah. So it's the one that we see in movies where they pick this thing up. Number one, nobody's looked at an ECG. They just grab the defibrillator, right? And then they go, and then clear, and then they do it. And they always do it for a straight line, you'll notice. And the heart magically starts up, all right? Because it's the easiest thing for the layman to understand. Nothing on the ECG, bad. Something on the ECG, good. So that's why they keep on doing it, all right? But the truth is that's not how we do it in real medicine. You never rub the pads together, never ever, okay? Because you're just going to scratch them and make them actually, they'll become less effective as it goes on. So what you do is you grab the pads in each hand. Now that's my hand holding both of them at the back, all right? And on top of them, you put gel, just 2 5-rand pieces of gel, no rubbing involved whatsoever, all right? So that's how you hold it. It is very possible to hold it in one hand, or you can hold it in 2 hands and somebody else can put the gel for you. It doesn't make much of a difference, just so long as you don't rub it like that. And that's how you position it, all right? So apex and sternum. So you can see the entire heart is kind of stuck in that little triangle where it should be, okay? Right. Now you may be wondering, all right, what do we do for kiddies? And most of them come with built-in children's pads. So like with ours, that little thing on the side, if you press it, it releases the adult pad, and you've got these lovely pediatric paddles on the inside. And most of them are built that way now. Okay. So when you pick it up, have a look. You know, like if you're working in a new emergency department, take a walk. Nobody's going to think bad of you if you pick up the defibs and look at them. You know, they'll know that you're looking for something. So at least do that, okay, so that you can see what's going on. Let's talk a little bit about the drugs. So we've got adrenaline that we've been using, all right? So adrenaline is inotropic and chronotropic. Inotropic means force, all right? It increases the force. Chronotropic means it increases the pace. All right, so it's giving you a harder, faster heartbeat. All right, it does cause peripheral vasoconstriction, which is good because you do want all your all the blood to be brought into the central circulation. All right, the problem is it can be a double-edged sword because what happens is that you've got increased myocardial O2 consumption. So your heart that's already damaged is now using more oxygen, all right? And then you've got decreased blood flow to the non-vital organs. So you can't keep on giving a person adrenaline because the kidneys are eventually going to shut down. They're going to have peripheral problems with the toes, fingers, nose, things like that, all right? So that's how adrenaline functions. So now what they're doing is they're trying to focus on combining adrenaline with beta blockers, because beta blockers slow the heart down, all right? So they're trying to work on that. And in some centers, they don't use adrenaline at all. They use vasopressin. Vasopressin is a vasoconstrictor. So instead of making the heart work harder and work faster, just do the peripheral vasoconstriction, force all the blood to the central circulation and see how that works. But it doesn't always work. Now, there is a drug called endothelin-1, which kind of combines the best of the two, all right, in that it does cause, it does allow you to get some peripheral circulation, but with good chronotropic and inotropic results. But it's still in the testing stage. It's only in animal models currently. But in a few years' time, you guys may well hear that you're using a drug called endothelin-1, all right, because it has been promising. Okay, so the end goal of resuscitation, any resuscitation, is to achieve a return to spontaneous circulation. In other words, the heart must restart on its own, which we talked about, all right? And the ultimate goal is to have normal cardiac and neurological function at the time of discharge, all right? So a lot of the times when we look at the stats, the stat talks about a few things. Initial resuscitation successful, but discharge is unsuccessful. So in other words, you have a patient now who comes out who has hypoxic brain damage. You know, the resuscitation could actually have been the worst thing for them, you know, if you get what I mean. Or patient now who needs constant pacing, who has severe ischemia, needs a heart transplant. So these are the things that we look at. Okay, all right. Let's have a look here. And then amiodarone, which we've all been looking at. So amiodarone is a very interesting one. It causes a depression in the automaticity of the SA node. Basically, what that is that it slows down the SA node, all right? Increases the refractoriness of the AV node. So you've got this SA node that's going slower and an AV node that's responding faster. So in other words, it listens more. So you've got this going slowly and this one here that's listening more. So it also starts to go a bit slower. All right. That's why it helps for tachycardias, because it's just slowing everything down. All right. Now you may ask, what's the value of that in a heart that needs to work harder? These patients have ventricular fibrillation. So number one, the heart doesn't know what it's doing, or it's got ventricular tachycardia. So what you're trying to do is separate the atrium and the ventricle by doing this. So you're slowing down the atrium, slowing down the ventricle, and allowing them to get their messages right. Okay, it's kind of like me and you talking, but we're shouting at one another extremely fast. And then we kind of slow down and I say what I need to and you say what you need to, and then, or you listen better to what I'm saying. You get what I mean? So that's a simple way of putting it, but that is essentially what is happening. All right. So the ARREST study. Now, the whole thing is called ARREST, right? It's an acronym. So it's a randomized clinical trial on the efficacy of amiodarone. It was based on ventricular fibrillation and pulseless VTAC, all right? So there are no studies on efficacy in hemodynamically stable patients. So what that means is that they did it on unstable patients, all right? So let's just see what they found. I'm also going to show you a pacemaker in this one. Oh no, this one is just about the pacemaker, sorry.
Defibrillation is when we shock the heart back into rhythm, like when you see them use paddles and gel on television. Fortunately, we now have devices called ICDs, or implantable cardiac defibrillators, which can shock the heart out of dangerous or deadly fast heart rhythms back into normal rhythm. The devices work all on their own. You don't need to be in a hospital, around medical personnel, or even around any other people at all. An ICD is a relatively small computer and a battery wrapped in a metal can. It's inserted under the skin, but outside the chest cavity, and has one or more wires that connect it, via the veins, to various chambers in the heart. The wires allow the ICD to sense or see what the heart rhythm is doing, as well as pace the heart to increase its rate if needed. Or it can shock the heart into rhythm when needed. A typical ICD initial implant involves bringing you into the hospital, where in the EP lab, we give you some medication to sedate you. You typically aren't completely under or on a breathing machine. Rather, we make you sleepy and comfortable so that you won't feel or remember anything. Then, we numb the skin and the area where the ICD goes on the chest. We make a small incision, and through that incision, place one or more wires into the vein. Via that vein, we pass the wire or wires down into the heart. The other ends of the wires are then connected to the ICD, and the ICD tucked in under the skin and closed up with stitches that will self-absorb. We typically keep you in the hospital overnight, and if all goes well with some testing the next morning, you are usually discharged to home. You will have instructions before leaving the hospital on the do's and don'ts, including how to care for the incision and limitations on lifting and moving the arm on the side of the ICD. Once implanted, we typically follow or check ICDs every 3 months or so. However, you do not have to travel to our office for that. Fortunately, this can usually be done from the comfort of your own home using a monitor, which we will provide to you often before you leave the hospital. ICDs have batteries, and as such, the batteries eventually run low. They typically last several years, depending on how much they're being used. However, it's not like the battery in your TV remote in that it just suddenly stops working. Rather, the ICD actually alerts us when the battery is nearing time to change. And then we have several weeks to arrange for that to be done. When the time comes to change it, we technically don't just change the battery. We change the battery and the computer unit, what we call the generator. But the wires do not need to be changed. Thus, you usually go home the same day as that procedure. We will discuss the risks and benefits of your initial ICD implant in more detail in person. But briefly, the issues we're concerned with at implant include infection, bleeding at the site in the chest or around the heart, as well as collapsed lung.
Okay, so just a little thing on ICDs. All right, now the rest of the presentation is more just fun stuff, all right? Things that are in the future. So before we get on to that, I just want to make sure we remember the rhythm, all right, of what we are doing. So patient comes in, there's no pulse. They've got either ventricular fibrillation or a pulseless VTAC. And that's what we see. So what's the first thing that we do? Shock. All right. If it's an adult, 150 or 200. All right. If it's a child, 4 joules per kilogram. All right. How do you get the kilogram? Guesstimate. All right. Ask the parents. There's lots of ways to do it. I'll show you in the next one that we're doing. Okay. So if shocked, then what do we do? CPR for 2 minutes. And then what's the first drug that we give? Adrenaline. Excellent. All right. And then we continue for 2 minutes. All right. And then we look at we check for a pulse and we look at the screen. And if we still see a VFib or a VTAC, what do we do? Shock again. All right. What's the second drug that we give? Amiodarone. Okay, so amiodarone is given in this way. That's the only thing I didn't tell you was the dose. The first dose is 300 milligrams, and the second or third time that you go through, it's 150. Okay, but that's not, you generally have that up on something. Okay, so even if you forget, don't worry, because you've got a few minutes before you get to that step. All right, so you've given amiodarone, you've done CPR for 2 minutes, you come back, you look at your pulse, there's no pulse, and what do you see? VFib, VTAC. So what do you do? Yeah, shock, sorry. Yeah, you're right. Shock, sorry. And CPR. All right, so you got it. So it's essentially what we learned the last time, just with those 2 extra steps of shocking and giving amiodarone. All right. So the thing is that rhythm must always play in your head. And if you're doing something where it's not necessary to know it all the time, but go back once in a while and refresh yourself. Okay. So if any of you have anything to do or want to go, it's no problem. But the rest of it is quite a bit of fun. You want to go? Yeah. Oh, okay, no problem. All right. Okay. No, that's fine. All right. So, yeah. Piercings are not a problem, but generally if you have hair, you have to try and take it off quickly. All right. Okay. So the ICDs, all right, once they're implanted, the question is now, do I defib a patient who has one? What is an ICD? It's an internal cardiac defibrillator. So the answer is no. You allow the ICD to cycle through its defibrillations on its own. All right. So we'll just see how that goes. So you can see this guy. Right now with him, they're doing it with pacing pads. All right. But it's the same thing as what would happen with an ICD. This is what you would see. There's no sound on this. All right. Okay. But can you see? All right. So it's just cycling through. So it keeps on cycling. It can cycle about 3 to 4, even 5 times. But once you see it stop cycling, and now the patient is still not doing well, then you can start with manual defibrillation. But basically, and then when you do decide to do manual defibrillation, the most important thing is just keep the pads away from the pacemaker, all right? In whatever manner, be it, it's most commonly placed here, because they know if you need defib, then this is the easiest place to place it. But sometimes it's placed on the right for whatever reason, abnormalities on the left-hand side, easier access from the right, whatever it may be. You can even go front and back, it's no problem. Okay, so whatever is easier. Any idea what this is? Looks funky, yeah? See it? Huh? Hey, not bad. You're not far away from it. Eh? It's called an LVAD. LVAD, all right. Left ventricular assistance device, all right. This is an LVAD, all right. So this is not something that you need to know. It's just for fun, all right? Because sometimes what will happen is you'll have a walking, talking, live patient who comes into you with no pulse, all right? And a nice little scar over here and a little battery pack. And you may faint because you think this is a zombie that's walked in here, but it's not. So a lot of patients have LVADs, all right? So what happens is you can see there's this little exit pump here, all right? So there's a little pipe, sorry, that's leading out from the left ventricle. And then you've got a generator, a pump, okay. And the pump is now going straight to the aorta. So in patients with severe left ventricular failure, what happens is that instead of the left ventricle having to do a lot of the work, it pumps whatever it can, but blood also flows straight through. You see, it's placed at the apex, the lowest point. So blood goes through. There's a pump here that actually sucks blood and then propels it through the aorta. But it's a pump. So it's working continuously, whereas our heart does that. So because that pump is working continuously, your patient has no pulse. There is blood in that vessel. It's just that it's not going up and down. So this just has a continuous flow. All right. So that's something interesting just to see, because LVADs, especially if you plan on specializing in emergency medicine, they love LVADs and LVAD questions, all right? Because those pumps have their own problems. They can trigger off something similar to pulmonary embolus. They can get septic. They can overload. There's so many things that can happen with them. So you need to know them, you know. But generally, what you call it, you can also get right ventricular and biventricular. So it just depends how many connections you have. Okay, right. Yeah, that's what we're getting to now. Don't worry. So this is a pulseless patient. If you put on the what you call ECG, they've got severe arrhythmias, but they're awake and they're talking to you because that pump is doing all the work, right? So you do not perform CPR unless absolutely necessary, because you can easily detach those tubes. Okay. BP and sets are very difficult to get because you have this continuous flow. All right. So all of our SATS machines, BP machines are all related to systole and diastole. All right. So they can't really pick it up. You do defib as normal if needed. All right. If needed. But there's a few things that go along with that. I thought I had it. So all of these LVAD units, now this is just for fun. Don't stress. All right. One day in the future, when you're head of cardiology somewhere, all right, at Harvard or something, then if you need to know it. All right. So each LVAD that comes, because it's such it's not a common device. They all come with a direct line to the LVAD supplier or customer service agent, or what you would call it, liaison, all right? So when something goes wrong, the first thing that you need to do is actually phone that liaison and tell them, I have a patient sitting here. It's got an LVAD and who is struggling. It's going to failure. It looks like an ischemia, whatever it may be. The pump is failing, whatever they may be. All right. So they will actually instruct you on the steps to go through, you know, and they have a thing to do. So what the easiest thing that normally helps for these patients is just to plug them in because their battery is dying. Seriously, 90% of the time, that's what happens. All right. They will advise you against any CPR whatsoever, because if you dislodge that pipe from that ventricle, dislodge pipe from the aorta, boom, everything's just come out, you know, you've killed your patient anyway. they give you ways of actually trying to figure out the SATs, trying to figure out the BP. There's particular, I think there's some equations that they use. I haven't had a chance to do it myself. And then the defibrillation is the last resort, because remember the defibrillation is passing electricity through the pump as well. So it can easily cause what you call malfunctions of the pump. So if it's absolutely necessary, they explain to you exactly how to go about it, you know. So it's very rare for it to happen. Just like pacemakers don't really break down all of a sudden, LVADs also don't break down all of a sudden. And if they are breaking down, it's simply because they need to be charged. So these patients they've got an external battery pack because they need to plug in every night when they are lying down to recharge that battery, you know. So it's very rare for it to happen. But it's a nice thing if you want to go and read about it, because it's fun. You never know. You may get one of these patients, you know. You may end up doing a locum at Santon Mediclinic or Life or whatever it is. And that's where the biggest concentration of LVAD users are, because it's so expensive. It's not covered by what you call it, medical aids in South Africa unless it's absolutely necessary. So you tend to have those rich folks, you know. So we say Amhlanga, what's it in Cape Town? What's that bay called? Hey, Camps. Hout Bay. If you go to those rich areas, that's where you may find somebody who's got it. All right. So almost the end. Now, this is a Syncardia total artificial heart. All right. Yeah. But this is, I can't remember his name now, but he was the first person fitted with the Syncardia total artificial heart. And I can see he's sitting on that, and that's his battery pack. Okay, for the artificial heart. Okay. But it's a complete artificial heart, all right? I know they put him with the basketball, but I can tell you he won't be able to play basketball, not with that, all right? So this is what it looks like, okay? Essentially what you've got is each valve is replaced by one of these, okay? And then it basically moves blood through these tubes from one sort of, how can I put it? From one chamber to another, but there's no physical chamber. It's all the tubes, and each tube runs through one of the valves, and the valves propel it and propel it and propel it. Okay, it's a lovely thing. It's a very intricate and involved process to actually stick it in. There you can see. So the entire heart is removed. You have an inflow from your IVC that's eventually going to an inflow in your, or what would be your left ventricle, a right ventricle that then passes through your pulmonary circulation, that comes back to what would be your left atrium, that then goes to what would be your left ventricle, that pumps into your aorta. Okay, so there's no heart over there. Now, there's a lot of things that go into it, the preparation, the readiness of the patient, placements, growth of the patient. There's so much that goes into it. I'm not worried about all of that, because this is the thing that you do when you become a super specialist in cardiology, and, you know, there's, what you call it, biotech and things like that. You know, that's when you really get into this. But it's just fun to see, all right? So that's why I say let's just start. But me and these animations, I don't know why I did that. This was another one that they used to have before. I'm just trying to remember the name of it now. It just slipped from my head. But this was actually a much easier one to use and resembled a normal heart. But the problem was it used to fail quite often. So they stopped with that one. Right. So any questions or anything anybody's worried about? Everybody's tired. I know this was a long one. Yeah. Sorry? Syncardia. This is the Syncardia artificial heart. There's a few of them that are out, but this is the one that seems to have gained the most traction. But there's some new ones. They're always developing new ones. Yeah. So it's just that if at some point you decide to get into the field of cardio and cardiopulmonary surgery, that's when you really be involved with all of this, because it's extremely complex. You know, the patients have to be placed on bypass for long periods of time. It's not easy to get those vessels actually attached to these machines, you know, and things like that. But at the end of the day, it is basic plumbing. It's just plumbing on a machine that's running. You know, that's the thing. So it's not easy, but it is really lovely work if you get a chance to do it. And I hope one of you will get a chance to do it and come back and tell us how it goes. Okay. Is it a placeholder until one gets a chance? Sorry? Is it a placeholder until one? It can be, and in some cases, like the guy who was sitting on the basketball, I think he waited for quite some time, because in the US, they've got an even longer waiting list for transplant. So it just depends. But there are a lot of people who are using it as placeholders, And some people have been kept on it for quite some time. I think the longest one was about 15 or 16 years that somebody stayed on it, all right? But that was really pushing it, yeah? That's the thing. So generally, as you were saying, it's a bridging device, it's to get you through from one point to the other. It has to do with the degradation of the membranes. It's not, there's something about the natural body tissue that gives it that longevity that some machinery hasn't been able to replace, So, as with any computer, as advanced as it may be, within a few years, there's glitches and this problem. Even with us, we also glitch and we have problems. But generally, machinery tends to have it more often, And the more complex the machine, the more glitches, So, yeah, that's basically what it is. All right. So hopefully you guys found that last part interesting. And then next week we'll do pediatric resus. And then we're going to have one where I'm not going to talk and you guys are going to resus a patient. Okay. All right, no problem. All right, everybody enjoy your day in this one. All right, no problem.